The glenohumeral joint, commonly known as the shoulder, is a multiaxial synovial ball and socket joint designed to maximize our upper limb's range of motion. But this extreme mobility comes at a steep mechanical cost. Because the skeletal articulation is exceptionally shallow, the joint lacks bony congruence and is inherently unstable. Preventing the arm from completely dislocating under normal use depends entirely on a complex secondary network of soft tissues, ligaments, muscles, and a specialized cartilaginous rim. This diagram illustrates the skeletal mismatch at the shoulder's core. A large hemispherical humeral head rests against a shallow, pear-shaped glenoid cavity. To compensate, a fibrocartilaginous rim called the glenoid labrum wraps around the margins, deepening the cavity for baseline stability. This image maps the joint's key ligaments. The capsular ligament is highly loose, leaving the inferior aspect unsupported. Strength is added superiorly by the coracohumeral ligament. Nearby, the transverse humeral ligament securely straps down the biceps brachii tendon. Yet, even with these fibrous bands in place, the static restraints remain relatively loose. Without continuous dynamic tension from the surrounding musculature, the joint simply cannot withstand the heavy, functional, day-to-day loads. That dynamic tension comes from a specific group of muscles. This table matches the 7 distinct movements of the shoulder to their primary drivers, relying heavily on the vital rotator cuff group to act as active stabilizers. The axillary nerve runs next to the weak inferior capsule. Being unsupported, inferior dislocation is the most common failure, routinely crushing this nerve. Mechanical demand also causes stress injuries, rotator cuff damage, adhesive capsulitis, and supraspinatus tearing. Because each of these soft tissues governs a specific movement path, clinicians can physically diagnose the exact point of structural failure simply by mapping which movements are restricted in the patient. At its core, the biomechanics of the glenohumeral joint are defined by a strict physical compromise. It trades skeletal stability for maximum functional mobility. Keeping the bones safely inside the socket requires constant intervention from the passive glenoid labrum and the active tension of the rotator cuff. Ultimately, understanding that the inferior capsule will always be the path of least resistance and the axillary nerve its first casualty provides the critical baseline for evaluating any trauma to the shoulder.